The next topic will be diabetes and cancer, connecting the dots. The speaker will be Dr. M.V. Chandrakanta, who is a skilled and knowledgeable and distinguished oncologist who is currently attached to the RN Taker Hospital. And the chairperson will be Dr. Shumon Mollik, who is a consultant radiation oncologist currently. And the second chairperson will be Dr. S.M. Karthikeyan, who is a experienced surgical oncologist with 21 years of experience in his field.
Good afternoon, all, and thanks for giving us this opportunity. And over to you, Chandrakant, for this important topic, that how diabetes is related with cancer and its management.
Thank you, sir, for that introduction. Both Dr. Suman Malik and Dr. Karthikeyan, and I would thank Dr. Mridul Bera for this opportunity. So, very common question is, as an oncologist, what is the link between diabetes and cancer? And I have to connect the dots. This is for the first time as an oncologist I am presenting diabetes with cancer. Okay. How do I change the slides? So I think, sir, the slides are not shared. I'll just say like that only. Okay, sir. Okay, so it's one of the peculiar topics of diabetes and cancer. So there are two things to it. One is diabetes can have influence on cancer, and cancer also can have influence on diabetes. So whether diabetes causes cancer or not, this is a important question. So the answer is that diabetes definitely has an increased risk of cancer incidence, but diabetes in itself, is it a risk factor, is a question. So usually with diabetes you would see obesity, you would see unhealthy food habits, sedentary lifestyle, all other associated comorbidities also being a contribution for cancer. So definitely diabetes increases the risk of cancer by 10%. So that is a significant risk. And it is not just diabetes, it is the associated risk factors too. Well, so now coming to type 1 diabetes. So type 1 diabetes has got if you look into the reason for mortality in type 1 diabetes, the second most common cause of mortality in type 1 diabetes is cancer itself. So type 1 diabetes, right. Okay. Right. So this was the topic. This was my first slide of connecting dots, and then these were my first impressions. It's a difficult topic for an oncologist. So if you ask me to tell about chemotherapy, drugs, it is easier for me. But if you say diabetes and cancer, it is a difficult task. So if you look into cancers, 50% of cancers are preventable, and among the top 4 preventable causes is tobacco, body weight, diet, and physical inactivity. So probably the lower 3 has got a link with diabetes being there indirectly responsible. And then, so this is one of the slides that says that diabetes increases the risk of cancer, and cancer also increases the risk of diabetes. And these are some pathogenic mechanisms of hyperglycemia, hyperinsulinemia, and so on. Right. So does diabetes cause cancer? Yes, no, maybe. So definitely it increases the risk. And this is because it is usually associated with obesity, less physical activity, unhealthy food habits, and addictions. Right. So which are those cancers which are associated with poor lifestyle? It is the breast cancer, endometrial cancer, colon cancer, bladder, esophagus, kidney, stomach, and pancreas. So how does diabetes increase the risk of cancer? These are the postulated mechanisms. There is some insulin resistance resulting in more insulin, and that promoting cancer cell proliferation. Obesity, again, produces growth factors, estrogen, insulin, leptin, again, that will also cause cancer cell proliferation, chronic inflammation, and insulin-like growth factor levels. And then type 1 diabetes cancer is the second most common cause of mortality. It increased liver, kidney, pancreas, and lymphoma, but it did reduce testicular and prostate cancers in incidence. So this is some reduction in the incidence, and there is also increase in incidence. Then coming on to type 2 diabetes, 10% increase in the incidence of cancer and 10% increase in mortality once the patient is diagnosed with cancer. So there is increase in colon, pancreas, and liver cancer, and there is reduction in prostate cancer. The probable reason is if a patient is diabetic, the testosterone levels are lower than those patients who are not overtly diabetic. Usually type 2 is a metabolic syndrome. Because of more adipose tissue, there is less androgen levels, and that is a probable reason why the prostate cancer incidence is lower in a patient with type 2 diabetes. Right. So there is something called type 3 diabetes mellitus. Type 3 diabetes mellitus is if you have an exocrine pancreatic cancer or any exocrine disease in the pancreas, there is a diabetes mellitus that happens. And a pancreatic carcinoma at times presents with uncontrolled diabetes. Like a patient with uncontrolled diabetes may get diagnosed with pancreatic cancer over a period of time. So 30% of pancreatic cancers have a type 3C diabetes mellitus, and the probable reason is these pancreatic cancers secrete a chemical called adrenomedulin, interleukin 1 and TNF alpha. Probably these are the postulated reasons for developing diabetes in a pancreatic cancer. Right. So this is how diabetes increases or reduces the incidence and mortality in cancer, and let us see how cancer influences diabetes mellitus. So these are some case reports, and this is a molecule called UFT or tegophoururacil, results in fulminant diabetes mellitus and DKA. These are some case reports you have. So UFT causes some immunomodulation, has some interferon alpha-like activity, results in islet cell destruction. So there's also some thiamidylate phosphorylase activity, and that is a probable reason why you would see some events of type 1 diabetes mellitus and DKA happening with tegophoururacil. And then glucocorticoids are the ones that we often use either as a pre-medication or as a treatment in hematological malignancies. So as less as a dose of prednisolone of 1 milligram per kg per day for 3 days results in 70% increment in the insulin requirement. That is the impact of steroids on the insulin requirement, and probably this is both because of insulin resistance and also impairs beta cell production of insulin. Right. And then, so what modifications we can do? We can use some steroid-free regimens for vomiting, and for hypersensitivity we can use some cremorphor-free regimens. Right. And then you have some PIK3, AKT, mTOR pathway inhibitors. The pathway for glucose transport and also for cancer proliferation is this PIK3, AKT, mTOR pathway, and if you are inhibiting this pathway, the GLUT transporters are reduced and thereby resulting in diabetes. So if you use drugs like alpelisib, they inhibit the AKT, mTOR pathway, but if you use insulin, it antagonizes the anti-cancer activity of these drugs. So therefore, you are not supposed to use insulinomimetic drugs when you are using everolimus or alpelisib, because it will antagonize the activity of these drugs. So therefore, we need to be judicious in using insulin in these patients. So then coming on to immune checkpoint inhibitors, which are the say of the day today, and these can cause islet cell destruction and can mimic type 1 diabetes mellitus, and there are multiple reports of causing type 1 diabetes mellitus with pembrolizumab and other immunotherapy drugs. Right. So there is also some common genes between diabetes and pancreatic cancer, and the common genes may be a reason for pancreatic cancer and diabetes both, something to do with islet cell and also with cancer. So there are some common identified genes that cause both. Right. And then there is a famous question that whether if a patient with cancer eats sugar, does the incidence of cancer increase, or will the cancer multiply on eating sugar? This is a very famous question which all the patients and majority of them ask. Is sugar a white poison? Right. So the reason why we thought sugar increases the incidence of cancer is based on the PET-CT. PET-CT is a scan where we look at glucose uptake and then diagnose the site of cancer. So if there is, so what you can identify is cancer has more glucose uptake than the normal cell. They are more glucose hungry. They like sugars, right? So does that mean that if a person takes more sugar, the cancer is going to grow? So is sugar dangerous, or does it fuel cancer growth? This is a very famous question, and the answer is simple. If you look into the glycolysis, there is something called aerobic and anaerobic glycolysis. With the aerobic glycolysis, you would see some 38 ATPs generated from one glucose molecule, where you have the pyruvate, and that results in 38 molecules of ATP. Whereas in the absence of oxygen, the pyruvate becomes lactate and the cell ends up in generating only 2 ATPs. So in an anaerobic environment, only 2 ATPs generated from one glucose molecule. What happens in a cancer cell? In a cancer cell, even when there is adequate oxygen, the cancer cell wants to prefer anaerobic glycolysis. That is, it will generate only 2 ATP even if there is adequate oxygen. This is called as the Warburg effect. Where in normal cell, 38 ATPs are produced in an aerobic environment, whereas in a cancer cell, only 2 ATPs in spite of adequate oxygen. This is called as the Warburg effect. So why does the cell, the cancer cell, choose to generate only 2 ATPs from one glucose molecule? The reason is simple. The cancer cell will use this glucose not just for ATP generation, but it will use the byproducts for nucleic acid synthesis. It gives more priority not for energy but for building blocks. So the evolutionary adaptation to harsh microenvironmental conditions by using carbon chains from the lactic acid as building blocks for synthesis of biomolecules like nucleic acids, proteins and lipids. So the cancer cell is glucose hungry not to generate ATP but to generate the raw materials for its cells. So that is called as the Warburg effect, right? So does sugar cause cancer? Eating sugar does not directly cause cancer, but consuming too much sugar can contribute to weight gain and increase the risk of cancer. There is no direct correlation between glucose intake and cancer cell proliferation. While cancer cells grow faster than normal cells and need more energy, giving them more sugar does not make them grow faster. So eating sugar directly does not fuel cancer growth, but high calories may increase weight gain and may indirectly increase the risk of cancer and outcomes. Right. So there is some evidence of metformin having some anti-cancer activity, it resulting in more apoptosis and cancer cell death. But the final say is there is a Nature article saying that there is something called drug repurposing, like we have sodium valproate, we have propranolol, we have celecoxib being used in cancer treatment. This is called drug repurposing. But the final jury is out and there is no conclusive evidence that metformin has anti-cancer activity till date. Right. So these are the standard lifestyle recommendations to reduce the incidence of cancer. Number 1, no addictions, no tobacco or alcohol. Number 2, maintain a proper BMI with exercise and diet. Fruits and vegetables and grains and are to be rich and low in meat. And the STD precautions and vaccination for HPV, limited sun exposure, screen for breast, cervix, colorectal and lung cancer if applicable. So the conclusions what we can have are 50% cancers are preventable. Diabetes mellitus increases cancer risk, may not be directly but as a surrogate. Cancer is the second most common cause of death in type 1 diabetes mellitus. Type 2 diabetes mellitus increases the risk of colon, pancreas, and liver cancer. Type 3C diabetes mellitus is the diabetes that you see in pancreatic cancer because of the exocrine pancreatic disease. Cancer drugs increase risk of diabetes mellitus. With modification, we may reduce it. Sugar does not cause cancer directly. The evidence for metformin is not conclusive in treating cancer. So thanks all of you for your patient hearing. Thank you, sir.
Thank you, sir, for the excellent talk and touching all the salient points with even speaking about the common misconceptions that sugar feeds cancer. It was very elusive talk. Thank you for sticking on to the time as well. The house is open for questions.
Thank you.
Thanks for that wonderful talk. I missed some of it, but from whatever little I understand, there are links between diabetes and certain types of cancers. These are associations, presumably. But there's definitely a link between obesity and cancers. So how different is these two in terms of the pathophysiology of cancer? If you can throw some light on it.
True. So if you look into the reason why sugar can cause cancer, these are the possible mechanisms which I showed. Yeah. So these are the possible mechanisms. One is insulin resistance itself results in more insulin that may accelerate cancer growth. And as an obesity, you have these hormones like estrogen, probably that is the reason why you see more breast cancer, endometrial cancer, and obesity with diabetes. And diabetes is a chronic inflammatory situation resulting in immune dysregulation, and that may increase the risk of cancer. And insulin IGF levels correlate with the aggressiveness of cancer. So these are the probable reasons why, with or without obesity, these are the mechanisms how you would see cancer.
I have a very simplistic question. I may be looking too simplistic. And we know that in insulin scenario, with insulin resistance or whatever, the IGF, the insulin growth factor, accelerates the process of carcinogenic cells, maybe. But on the other hand, if we use metformin, which is insulin sensitizer kind of things, or other drugs like pioglitazone, which will impact more on the effect of insulin, so more of kind of effect on malignant cells. So do you think the factors that you have been talking about as far as metformin and other sensitizers, maybe as far as diabetes treatment is concerned, will aggravate the scenario?
So there is no conclusive evidence that anti-diabetic drugs reduce the incidence or aggressiveness of cancer, but insulin secretagogues like sulfonylureas or insulin, these may antagonize the activity of anti-cancer drugs. So therefore, there are some targeted therapies that work in the same pathway where insulin works. So if I am using insulin, I am antagonizing the activity of anti-cancer drugs like everolimus or alpelisib and so on. So if I am using metformin or let's say SGLT2, we are trying to reduce the insulin resistance and the insulin levels will probably come down. So I think that is the reason why metformin has been so much talked about its anti-cancer activity. Thank you.
Thank you very much. Thank you. Thank you, Dr. Chandrakanta.
With this, we come to an end with this wonderful speech. I'd like to call upon Dr. Sanjay K. Shah. I'd like to call Dr. Sanjay K. Shah to facilitate the speaker and the chairperson with these mementos.